good evening, everyone, and thank you for logging in for this very interesting session today. I feel transplants and thalassemia is a very important and very complex subject. I also personally feel that it's one of the most difficult transplants to do because the outcomes of the transplant are not only dependent on the donor types, but also to a great extent to the host, and that is the type of thalassemic patient you're dealing with. And of course, there is lots to discuss on the conditioning and other things. We are the thalassemia capital of the world. In the pediatric transplant practice, almost 30% of the transplants which happen in India in the allogenic field happen for thalassemia major. So hence it becomes a very important subject, and I should thank CELON to bring us all together on this platform to discuss this very important aspect of our practice. I'm also fortunate to have a battery of experts in the field who have a tremendous experience of decades in working in the field of transplant, and especially with thalassemia major patients. It's a pleasure to be kind of sharing this platform with my teacher, Dr. Sajid Prakash Yadav, and also my colleagues and friends from different part of the country and from very good institutes with tremendous experience in this field. So without more ado, I will try, I'll kind of start the proceedings for today. We have three components of today's session webinar. First, we'll be discussing risk stratification, which is extremely important in thalassemia. As I said, it's a very heterogeneous population, and every patient kind of has to be dealt in a different way. And with a focus on reduced intensity conditioning and its role in thalassemia transplants. So Dr. Satyendra Kateva, who is my friend, Senior Consultant Head of Pediatric Hematology Oncology at Manipal Hospital, Jaipur, is going to be discussing the first topic. And then we will be discussing another, I would not say controversial, but very frequently discussed topic about haploidentical transplant and thalassemia. And then we have the panel discussion, which is very important. And that idea during that panel discussion would be to highlight some of the unique complications, some of the unique aspects of thalassemia transplant, which will be monitored by Dr. Gaurav Kharia, and there will be panel experts discussing the various aspects. So I'll hand over to Dr. Satyendra Kateva to start the proceedings with the risk stratification and the reduced intensity conditioning. So for all the audience, who just post your question in the Q&A session, I will try to collate them and ask them to the faculty once the session is over. Over to Dr. Kateva. Thank you very much.
Thanks, Sunil. Good evening, sir, and thank you everyone for the wonderful opportunity to be talking to all of you. And the topic, we are doing webinar for almost like 10 months, but this is the one which is very, very close to my heart. And this is primarily, as Dr. Sunil said, that this is a topic which not only needs the expertise into the transplant, but you have to understand the disease in entirety before, to produce the good results. So the two things are risk stratification and RIC. Now we can understand in transplant, both are to do with the patient.
Can you share your slides, please?
Didn't I? I did. Can you see them?
Yes, sir. Please go ahead.
Yeah. So the topic that has been given to me by Dr. Sunil is the risk stratification and RIC. And you see the both of them have to do with the patient only. But in every disease, conditioning has to do with the patient. But the risk stratification, other than leukemia, this is probably one area which is very, very important to understand before we decide or we plan a patient for the transplant. So in the given next 20-25 minutes, we'll try to see what has happened over the first transplant for thalassemia happened way back in 1982. And since then, it is like 2020. So over the last 38 years, what has happened? So how the groups have evolved, what are the conditioning, where we have reached from MSE to RIC, And I'll try to, give the very, very basic idea why we do the way we do in transplant, and if there is anything we can improve, what are their impact on the transplant outcome, and I have nothing in particular to disclose, just that it is an online meeting. Now, HSCT and thalassemia measure, whenever we talk about, and why Sunil had chose this subject in particular for a country like ours. And you see almost 10,000 thalassemia measure are born every year in India only. And you see the impact of this disease onto the economy of a poor country like ours. You see the arrow. By the 15 years of age, a thalassemic has already taken around 250 to 300 units of the transfusion, and the family already has spent around 16.5 lakh rupees onto the care of the child. And if that child is fortunate to live for 50 years, by then it is almost like 1 CR. So anybody, it's a disease which actually make you bleed money for the family. And the government, as a country, we have a progress over the time that most of the centers are doing it. The family doesn't have to pay. But we have to understand that, the cost of transplant in front of the care for the thalassemia, and the care doesn't mean just the blood transfusion. It is a very different ballgame altogether. So the cost of transplant in front of the whole thalassemia care is very, very minuscule to me. If you see a 4-year-old thalassemic child, the cost of transplant is somewhere between 8 to 15 lakh rupees. And if we see around a 15-year-old, where already 15, 16, 20, 60 lakh, 1 crore by 40, 50 years. So this cost, which gives you cure, is very, very logical and very, very appropriate to me. So I respect the people who are taking care of the thalassemics with the supportive care, and I respect them a lot, because with their care, it is the transplant outcome which changes. But if the cure has to come, as of today in our country, the only cure which is possible is bone marrow transplant. And this is the sad scene again. Over 1 lakh thalassemia patients die before. And the more unfortunate thing is we do not have the official data. So the data into this and the news has been collected from various NGOs and all that, and that's the sad story. But we can say now, with the care of thalassemia, a lot of children can do this, that, and all that. They don't need a transplant, but that's the reality of the story. The majority of them, even the supportive care, a good supportive care is not possible. So whenever there is a possible, we should go ahead and give a cure to these unfortunate patients and make them feel as normal, and that's the real win for the humanity. Now, whenever we start talking about a risk grouping for any disease or the conditioning, so in bone marrow transplant, conditioning is something which majority of the newcomers or the majority of the young transplanters think that if I know what conditioning is to do, I can do the transplant. So let us start from here. The two components are there in conditioning, which is there. Whenever we think of giving a conditioning, our whole idea is to wipe out the bone marrow of the patient. And there are two different components of the major component of that marrow. That is, one is the myeloid and one is the lymphoid. And based on these two, how do you want to deal with which one is the question. So the other important thing is that the toxicity of the marrow and the toxicity of the normal organs. The toxicity of the bone marrow usually recovers with the recovery of the donor cells, whether it's a 100% or the mud donor or the haplo donor, whatever it is. But the toxicity of the normal organs, we cannot go beyond a certain limit if the other organs are not tolerating it. So it's not only the bone marrow and toxicity, it is the other organ toxicity which is also important, and that is probably way more important than just the bone marrow. And that is that concern and that smart thinking now changing the thing, that now the thought process of conditioning is just you give a shock to the bone marrow of the patient and then let the healthy donor cells do a lot of tricks, and you try to decrease the dose of this conditioning. Anyhow, traditionally, we have used these four things. busulfan, a very, very old and trusted player, categorically trusted. Now we see with the IV use, with the oral, they were concerned about the PKPD of the busulfan, which primarily targets the stem cells. Radiation in a higher doses was taken as a very, very safe agent to wipe out both the myeloid and lymphoid component. Cyclophosphamide, again, an agent that has been old and very trusted player, that it can deal with after a certain dose, can deal even with the stem cells and definitely the lymphoid component. And it was primarily for the lymphoid component. So, based on this thought process, we'll try to see how things are evolved. Now, let us start. This was the first patient, and it was done by the daddy of bone marrow transplant. the Nobel laureate Professor E. Donald Thomas. And it was way back in 1982. And if you see onto the right side of my computer, you can see that few people are blessed. And what he did, that he just used busulfan 5 mg per kilo total dose, and he gave cyclophosphamide 200 mg per kilo. And he did transplant from a identical twin. But you see from a sibling rather than this, and he could get away with this, right? Now you think of it today, if somebody asks you, oh, you just give 5 mg per kilo of busulfan and 200 mg of cyclo, can you do that? I'm sure you will never ever, you will even stop talking to that fellow. That, oh, this is not possible. But these were the blessed souls by the God. They decided something, they did something, and God blessed them with that thing. So I think it was just the blessing of the God, the first patient which got for the thalassemia, and it was cured. And if Professor Donald Thomas was the daddy of the bone marrow transplant, here is the daddy of the thalassemia bone marrow transplant, Professor Guido Lucarelli from Italy. So it was the first paper where he has presented some 13 patients. And if you see, this is very, very important to understand that out of these 13 patients, some 6 patients were into the, what should I say, early disease of, and in the 7 patients which were there into the late. So, late means the patients were of the higher age, lot of blood transfusion has given, the liver was not in good situation, hepatomegaly was there and all that. And out of the 13 patients, 7 patients survived after this bone marrow transplant. And you see the conditioning Professor Lucarelli used was Psi-TBI, then he thought of increasing mu from 5 to 8 mg per kilo and with Psi of 200. And then he made the busulfan, the famous 16 mg per kilo. And then rather than Psi, he used TBI 400. And then he had, guts to do even the 16 mg per kilo of busulfan with 200 mg of cyclophosphamide and 400 mg of TBI. So see, even in 13 patients, he tried 4 things. And he found out that the last one is too aggressive for the patient. And he said that 5 of the 6 patients were primarily because of, the transplanted mortality was primarily, a lot of toxicity was there, rejection was not a primary problem. Anyhow, this was the first time that in a patient, in 13 patients, he proved that 15% or more than 15% of the patients can be cured. And you need to give them some busulfan, probably some 16 mg per kilo, and you need to give them a cyclophosphamide 200 mg. But he said the busi and then TBI is a bad idea. Anyhow, and that was, from 5 mg total dose of busulfan to 200 mg. This paper was in 1984. Just in 2 years, the science traveled at a very, very rapid speed, and 13 patients came out with 4 conditioning regime. The one was, taken as a caution not to be used, but 3 more came just from the views, and Psi to it came view, Psi, and the TBI also. So why do we care about, what we are doing is, right? So the cure of thalassemia, this famous paper again by Professor Lucarelli, that taught us that why it is important to decide what is to be given. So what is to be given is based on what your patient is looking like, how good your patient is. And for that, he actually devised a risk category. But before we go ahead and do, we have to understand that this component where we give chemotherapy, immunotherapy, ATG, a lot of serotherapy, right? And these all things are organ toxic other than the myelotoxicity. So this is important to understand that one of the primary organ which actually deals with the chemotherapy is the hepatomegaly. So anyhow, Professor Lucarelli said that based on the iron chelation, the liver swelling, if there or not, and the fibrosis perisinusoidal, they can be classified into class 1, 2, and 3. And the 3 is the worst, where even chelation is not okay, the liver is swelled up, and the fibrosis is there. And the class 1 is the cleanest one. And he said that these are important, and why they are important, here is the answer. So he used a view of 14 mg per kilo total dose in study of 200 mg, and these were all matched sibling transplant. And he said that if I forget about the class 1, class 2, class 3, almost we can cure thalassemia-free survival of 75%. But why Professor Lucarelli, why he is called as the daddy of the thalassemia transplant is this. He said that class 1 and class 2 patients are, this 75% increased to 85 to 90%. But what his problem is the class 3. In class 3, he said that it just come down to 55 to 60%. And lot of mortality, almost 20% mortality, 30% rejection. So he said that if your thalassemia patient is into the class 3, it's a bad category. And he said that for them we need to do something, other than. But those are the developed countries where class 3 means that the supportive care has not happened the way it should have happened. So the blood transfusions might not have been given on time. The iron chelation might not have gone on time. A lot of other organ functions might not have been taken care of. So that is how a big spleen might have been there, because you kept hemoglobin around 7 or 8. So, there these patients class 3 were less, but you think of India, in India it's a problem. So that is how the Professor Lucarelli taught us class 1, class 2, class 3, and class 3 is bad. But what the Indian experience says, so this slide I have taken from Professor Alok Srivastava. He did a presentation onto the WDMT. And it was the same experience of the India also. But you see, what I want to emphasize all of you is that you see class 3, almost 50 to 60% of our patients are into class 3, right? You see 2/3 of our patients have a liver size more than 2 centimeter. 90% of our patients have inadequate chelation, and almost 70% of the patients have liver fibrosis. Now, this is our patient population, right? So, we thank Professor Lucarelli for that, but we try to, see that thing into our patient also, and we realize that class 1, class 2, class 1 in India, you see into this data only 4 to 5%. Class 2 probably 40%, but class 3, majority of the class 3. And they also confirm the same, that is class 1, class 2, they do well from 80 to 90%, but class 3 is bad, it comes down to 60%. And categorically, they raised a question into their data, the CMC Valor, and we give credit for them, that they say, okay, Professor Lucarelli left everything at class 3, but they both patients, as per Professor Lucarelli or the Italian data, the Pissarro risk group, they come into the class 3. But you look at, these are two patients where the liver size is 7 centimeter versus 3 centimeter, a spleen size of 5 centimeter versus spleen not palpable, a fibrosis of +2 versus 1+, and the age 14 year and 6 year. So as per the Pissarro classification, both are class 3, but we know here that, okay, they are class 3, but we know this patient class 2 is probably class 5. It is not even class 3, right? So maybe in India, class 1, class 2, 3, class 4, class 5, there are a lot of class. But anyhow, we decided that out of class 3, can we decide can we tease the data further? And that's what we came out with. That even in class 3, there can be two groups. One can be class 3 low risk, and the other can be class 3 high risk. The two parameters which decided, which came out statistically significant was the age, if the patient is more than 7 years, and the patient's the liver size, the hepatomegaly is more than 5 centimeters. If both are there, then you are into class 3 high risk. And if you are not there, both of them are not there, then probably you are class 3, but you are low risk. So when, we told the world that, okay, here are the two data, and that makes class 3 into the further, two subcategory. And then the world took this data again from us, and then they, explored them into the patient from Canada, Europe, and the Indian combined. And that's what also, they also confirmed that, okay, class age more than 7 and the hepatomegaly more than 5 centimeter are definite, the parameters, and even the whole world also feels the same. But I also want to say here, if you are more than 7 years with the hepatomegaly, your chances of cure are just 55 to 60%. But you have to remember that, these are very, very bad patients. But if your age more than 7 years, but your liver is okay, you see, we are still 85%. So it is, rather than the age, here also, they certainly suggest that it is more to do with the liver, and the liver is one of the primary organ. So rather than age, it is the liver and the chelation. They decide how good or bad you are going to do in your transplant. And I'll try to add one slide from my experience of some 42 patients as Kanipa, that now probably we need to add more. And that's for almost 25 years. Can we add this to, can we add more to this, what we know today? And probably we can, and we are writing it up, and I will come back onto this. So this was class 3, and we understood that class 3 is bad, age more than 7, and hepatomegaly more than 5 centimeter liver, the patient is going to do bad. But you see, that's where here also the busulfan is the drug which was used at the CMC Vellore and the rest of the world data. And here also we understood that the busulfan pharmacokinetic is an important aspect. So this one significant paper which compared the busulfan, the dosing from the 600 milligram per meter square or the 16 mg per kilo over 4 days, along with 200 mg of cyclophosphamide. And they said that there is not a much of difference into the engraftment, graft versus host disease, and the disease-free survival. But they said that there were 6 patients who rejected, and 5 out of those 6 patients who rejected, the level of cyclophosphamide after the first dose was less than 150. And this paper actually put a lot of significance onto the pharmacokinetics of busulfan categorically with the oral busulfan, and that that the concept came that if you want to use the oral busulfan, we should probably have the levels, and the first dose level are probably more important. We should be into the myeloablative area rather than into the less ablative, because otherwise a lot of rejection will be there. Anyhow, so the boss gave us the problem, he taught us that, okay, class 3 is a problem. And then again, Professor Lucarelli gave us the solution to that also. So this paper came in 2004, and that's what he taught us. Right after telling us the problem of class 1, 2, and 3, after 3-4 years, he came out with this protocol 26. So in this protocol, he taught us that, maybe there is a better way of dealing with the thalassemia patients, that you from 45 to 60 days before the transplant, you suppress the erythropoiesis by giving hydroxyurea, you suppress the immunosuppression by giving azathioprine, and you intensively chelate the patient by desperal infusion, and you keep the hemoglobin very high so that the thalassemia bone marrow. So thalassemia marrow is a hyperactive marrow, so we need to suppress the marrow. So with this erythropoietin, simultaneously you are trying to give so that the marrow is not aplastic and it's still working. And with this cytoreductive therapy, you are trying to clean it up. Anyhow, with this, and then you give fludarabine, busulfan, and cyclophosphamide, and you see here the cyclophosphamide dose decreased from 200 to 160. You can see it here, right? And bingo, and he produced a result. But to all of you, the established transplanters and the young guns into the field, he also gave on day 1 a small dose of cyclophosphamide with a small dose of 7.5 kg per kilo. He used methotrexate on day plus 1, 3, 6, and 11, and cyclosporin for sure. But on day plus 1, he used a small dose of cyclophosphamide in protocol 26. And with this background, where you have suppressed the erythropoiesis, the marrow, and you have given the lymphosuppression also, and then you use flucide, and then you give small dose of cyclophosphamide post-transplant day 1, and he produced a result which was like, for the transplant, it was mouth-watering. For class 3 patients, you are talking like 85 to 93%, amazingly good results, right? So, so the boss gave a problem, and the boss sorted out the problem. But the problem with a poor country like India is, if you are going to start a patient for transplant from day minus 45 to 60, you are supposed to spend a lot of money to take care of that patient, because now it's now you are riding a lion, and you just cannot say in between, okay, just I'm tired, and you stop it. So you have to be on top of everything just from day minus 45, and that increases a lot of cost into this transplant. Anyhow, what has changed over here is that now we are giving more smart immunosuppression. We are giving more immunosuppression. Earlier it was just blue and side. Now we are doing a lot of things. We are more and smart immunosuppression. We have added fludarabine to the conditioning, and we are giving less of chemo. From cyclophosphamide decrease from 200 to 160, and first time we have used on day plus 1 the cyclophosphamide, and that have produced beautiful results. So this gave us less chemo, more immunosuppression, and do things more smartly, and you do things over a period of time rather than just 7-8 days of conditioning, and probably your patient will do well. Anyhow, there is another big boss into this field, and the name is Dr. Franco Locatelli. And Franco Locatelli came out with this paper some few years after the publication by Professor Lucarelli, almost like 4 years later. And he used a new conditioning, and the new conditioning was, we will be discussing here, but see here, a lot of patients in class 3, but then young adults also. Right? This is very, very important to understand. So what Professor Franco has done is that he has opened the floodgates of for the thalassemia patient, that if you have a donor available for you, and we should be transplanting you, and probably we need better drugs to do that. And what he used rather than the busulfan, he used treosulfan, and he used another agent named thiotepa and fludarabine. So you see it's here, there is no ATG, nothing over here. He used ATG into the patients where there was unrelated donor transplant was there. So treosulfan, thiotepa, fludarabine was the conditioning he gave into the young adults and class 3 patients. And if there was a patient who is class 3 and unrelated donor also, he used ATG also. And he also produced some amazingly good result in these young adults patients, right? This was the first time when now people were talking young adult transplant in thalassemia, and overall survival of 93% and thalassemia-free survival of some 85% into class 3 and this. Beautiful results, right? And this also taught us that you need less intensive chemo, you need smarter immunosuppression, and you need to find out a combination where your elderly patients whose liver is not that smart can tolerate it better, and there is definitely a space for ATG in these patients. So this was the message given by the second big boss into the thalassemia transplant, again from Italy, Professor Franco Lucarelli. Then again, the Indian data from CMC Vellore about treosulfan, and they also confirmed this, that yes, with treosulfan, your outcome can be far better in these patients if 86 versus 40% if you are using busulfan. And this is thalassemia-free survival, 78% versus 32. So this was a huge difference. But they also commented on into their paper that probably class 3 patients needs to be transplanted with treosulfan, thiotepa, and fludarabine, but probably they reject a lot of transplants, so we need to give them peripheral blood stem cells. They categorically said that into their paper. So we took it, simultaneously we were also doing transplanted BL Kapoor, me and Dr. Dharmaram Chaudhary, and we also published our data, and compare the busi and the thio and flu, and with the busi ATG, and you see a lot of patients with class 3. But we did not see the way the world has seen. Into our experience, the busi was still better. But now here it's not the traditional busi. We added ATG. So it was now busi and ATG. But here thio, and we haven't produced results at far, but there was reasons for that. In 90% of our patients, bone marrow was the source. But Vellore data says that if you use bone marrow, there is a lot of mixed chimerism. So why did not we see the mixed chimerism in our patients? And probably in all class 3, we were using azathioprine and hydroxyurea, and few of the patients using ATG. So probably the mixed chimerism were taken care of. But in our set of patients, it was not just 28 patients. In our set of patients, we did not find it that conclusive. Now, if you do not have a brother or sister available, how do you do it? So here comes the Chinese, and that's what again they have suggested, that you can make 3 groups less than 2 years, 2 to 6 years, more than 6 years. And you see even in group 1, 2, and 3, you see they are definitely decreasing the cyclo, and they are decreasing the dose of the busulfan, and the thiotepa and the fludarabine they are keeping same. So these are the which were the two traditional, the busulfan and cyclo. With the increasing age, they are decreasing the dose, but with thiotepa and the fludarabine, the newer drugs, they are keeping it almost same. And they also produce beautiful result even with the unrelated transplant, almost to the tune of 10%. This is beautiful. Now, then comes one center from Thailand, and they changed the way we look at the thalassemia transplants, and this was for the matched related and unrelated donor transplant. And that's where they used 2 conditioning regimes at Thailand Ramakiboti. One was myeloablative and the other one was non-myeloablative. In the myeloablative, they used busulfan, and this was 14 mg, cyclophosphamide, this was 200 mg, and they used ATG also, right, for the unrelated donor transplantation. In non-myeloablative, the busulfan and the fludarabine and ATG dose was also decreased, and they added TLI. And the patients who received non-myeloablative, TLI is total lymphoid irradiation, all for class 3 patients and with the unrelated patients. So in these patients, they used a TLI, ATG dose was decreased, and they used bu and flu. There is, you see it here, there is no psi over here. So just bu, flu, some ATG, some TLI. And they also produced beautiful results with the 49 patients of some 90% and 55%. And they reproduced them even into the 100 patients, and it's looking beautiful. So, this, what they have taught us, just further this, then they introduce these tools. Sunil is going to talk about them. That you start from almost 60 days before the transplant, you start doing it, and you induce a smart immunosuppression, and you can do a lot of good things. But John Hopkins, now look at the latest conditioning, which I want all of you to have a look at. What they have given: Rabid ATG, some Fludara, and TBI, and that's it. Can you believe this? Flu, TBI, and ATG, just 400 mg TBI they have given in all the thalassemics and the sickle cell patients, fludarabine, and then they use PTSI even into the match sibling also on the haplo, whatever Sunil is going to talk, and they have produced 100% results. So all I want to say is that if there is no match unrelated donor available, haplo, whatever it is there, Sunil is going to talk about, but the concept is less myelotoxicity, less organ toxicity, smart immunosuppression, and that is how we decided. Okay. Now the risk group, I said the last slide where we need to add more. I said that these are the two things: that the hepatotomy more than 5 centimeter is bad, age more than 7 is bad. But out of the two, it is the liver which is more important rather than the age. I have transplanted, Sunil has transplanted patients more than 20 years whose livers were good. They are doing fine. They don't have an issue. So rather than these two parameters, is there any other parameter? So now I am writing up the paper with 42 patients, and in my experience, that alloimmunization, even it's a problem even into the matched sibling thalassemic patients and matched unrelated donor patients. And this alloimmunization should be taken care of before the transplant. That helps a lot. And in haplo patients, probably we need to add anti-HLA antibodies to the list of age more than 7 years and hepatomegaly. And if your patient is class 3, hepatomegaly, more than 7, you probably don't do that. But even if your patient is having liver okay, age more than 7 years, but anti-HLA antibodies, then it's a problem. You treat it within the treatment, somehow you add the toxicity, lot of cytokine storm, lot of HLH, lot of transplant associated TMA, and that's for the poorer outcome. So we need the better things. We still need to work on to that how do we deal with this class 3, which is having anti-HLA antibodies or the alloimmunization. But other things are now getting better. Now we understand that we need to be less chemo, smarter immunosuppression. We need to be more, tender into our care rather than, we need to be very, very rigid about that, it has to be like this only. No, looking at your patient, you decide what component you want to switch. And that's what the work here at Manipal Hospital, Jaipur, we have done quite a lot of things over here. And that's the person I am completely, what should I say, mesmerized by, because he's the one who says that, if you're thinking something, you should try, go for it, and you try and see whether it works or not. And I completely agree with the thought process, at least in thalassemic patients. Because if everybody would have agreed with Professor E. Donald Thomas that 5 mg per kilo and 200 of cyclo, probably we would not have reached where we have reached. So with this, I finished my talk, and whenever the questions will be there, we are online. Thank you, Sunil. All yours.
Thank you very much, Satyendra, for this excellent overview. I think it's very difficult to do this, in 25, 30 minutes. It's a vast subject, and I think you have covered beautifully a lot of aspects of conditioning and the stratification and how it has evolved. There are a few questions. I think a couple of them will be taken up later on in our case discussion. These are more related to the complications post-transplant. There was a question, I think, how many transplants we do in India. It's about 250 to 300 for thalassemics in 1 year, all the centers put together, which I said earlier forms around 30-35% of transplant activity for pediatric patients. That's up to 18 years of age. Now, there's another one question which is being asked about busulfan pharmacokinetics. I think you mentioned that in your study, in your presentation. So the question is basically, how do you do it in the center? But I'll make it more broad. I think, is it available in India, and how feasible it is? So that is the question. And I'll add one more question to that, and that is, with the data which you showed us on busulfan with reduced intensity conditioning, if finances are not a concern, what will you choose? Taking finances aside, what will you choose? Reduced toxicity conditioning, or you will choose busulfan-based conditioning in absence of PKs studies in India?
So the first question, yes.
A little bit crisp, running out of time. Yeah.
So the first question is simple, that whether it's done in India. Yes, it's done at few centers in India. And but now with the IV busulfan, whether So if you are talking about the oral busulfan, yes, it should be done. It is that simple as this. But once the IV busulfan comes, the world has moved on, and the world is now, they just give a small dose of the busulfan, and then they see how the body is behaving. And based on that, they design the dose of the busulfan, and based on that, now the whole protocol comes up. Now in India, if you are doing 2 transplant or 3 transplant in a month, and you go and talk to your hospital about establishing the busulfan level in the hospital, yes, it can be done in every hospital, because all you need is a trained technician and HPLC machine. But to survive that, you send a sample, and then the technician is gone for the whole day. So doing it's more, it needs a lot of manpower, and it needs dedicated areas and dedicated technicians. Now the question comes up, if the family can afford, then I will definitely go ahead and do the reduced intensity, because of lot of reasons about that. The one thing is that there is a clear-cut data which is published, that the transplant-related mortality is less with the reduced intensity, and they have produced results at par or better than myeloablative. So both the reasons they compel us that if the family can afford reduced intensity, it should be offered to them, because it's not only better for the patient, but this is ultimately having an impact onto the transplant outcome. That's what.
Thank you very much. So we'll go to the next session now, which is on. Thank you, Dr. Satendra, for your for your inputs, and I will request you to stay back for the for your input during panel discussion. Now can we move to the second session, please? All right. So the second session, is on haploidentical transplantation in thalassemia. There'll be some repetition, but I'll tell you why this repetition is there. There are some things I wanted to kind of highlight and bring in picture before going to the core haploidentical transplantation in thalassemia. So why we're discussing this? Because as we know that only 20-30% of the times we'll have a family donor, a sibling donor for the patient who's a full match. And then what happens the rest, maybe 10-20% of the times we may find a unrelated donor from the registries. But then in the next 50-60% of the patients, there is usually not a family matched or an unrelated donor. So I think in those patients, haploidentical transplant is an option. Now, for any transplant, whether it's haploidentical transplantation, matched sibling, unrelated, thalassemia, as I said earlier, is a very complex disease when it comes to transplantation. We have to look at various aspects when a transplant as a treatment or a curative option is brought on the table for discussion with the family. It's not only about finances, which are very important in our setting, but also the risk valuation of the patient, the quality of life he's having now, and what's the quality of life expected post-transplantation, the risk of chronic GVHD, which can be itself a debilitating long-term disease, and of course, availability of the donor, age, and other risk factors, which Dr. Satendra has very nicely highlighted. So the counseling and the discussions which are on the table with the family are very, very complex, and I think a lot of time needs to be spent on that, so that everyone understands, what we are getting into. Now coming to the haploidentical transplantation, what are the advantages? The advantage is that we have got immediate donor availability. The donor is next to you. For every child, both parents are, are haplo donors. So practically, every patient will have a donor for them. In older patients, that usually it's about 80 to 90% times we'll have a haplo donor, but usually for children, we always have a donor option available for them. Another advantage is that donor is available for second transplant if required. Donor is available for any DLIs later on, and potentially less expensive, probably as compared to unrelated donor registered transplants from registries, where the expenses of the registries are quite high. But the major obstacles are, that we are doing transplant across HLA barriers, and hence graft rejections, graft versus host disease are very, very important. GVL doesn't really apply in our, thalassemia transplants, but of course, slower immune recovery and increased infection risk is another obstacle when we offer an haploidentical transplantation for a patient. Now, what are the unique things when we talk about haploidentical transplantation in thalassemia, and for that matter for any non-malignant disease? There are a few things very, very unique, and they need to be kept in mind, because most of the data, most of the discussions which happen, especially I would say in adult platforms and also in the platforms of international conferences, they're quite heavily biased towards malignant transplants. But in non-malignant transplants, you're dealing with a very immune competent host, and that immune competent host can be highly sensitized, which can happen in thalassemia major, for example, due to repeated blood transfusions, and which leads to high rejection rates. We have no need for graft versus host disease because we don't need any graft versus leukemia effect in normal disease. And there are a lot of ethical issues which probably need to be answered and discussed with the family before a transplant is embarked on, especially after transplantation. Now, this slide is important because that's something which we exploit in a transplant setting, and especially with a mismatched transplantation. We know that the stem cell graft which is put in doesn't only have stem cells in it, but it does have other cells, the B cells, the T cells, and the NK cells, along with the graft, and the T cells which are present in the graft. The majority of them are, 95% of them are alpha beta cells, but there's a minority of cells, around 5% of them are gamma delta cells. And this is very important because we can exploit this when we do graft manipulations in a haploidentical transplant setting. Now, every transplant, is an interplay, or it's a fight between the donor and the recipient lymphocytes. The donor lymphocytes, are important for engraftment. They're important for fast immune reconstitution. They help in relapse. Of course, not relevant in thalassemia, but they also mediate graft versus host disease. At the same time, the recipient lymphocytes are important because if they are there in the system and they're strong, they're going to mediate graft rejection. So this is basically, these two lymphocyte systems have to interact with each other, have to really fight with each other so that the transplant is successful and there is no residual effect in terms of graft versus host disease in the patient. Now, how do we achieve that? How can we do a haploidentical transplantation, keeping these graft components in mind and the different lymphocytes, subsets in the mind and what they do, from their function point of view. Now, we can do T cell depletion, which is ex vivo T cell depletion, and that can be done by indirect T cell depletion. That means you're just selecting the stem cells, which are CD34 stem cells. You can also do direct T cell depletion. That means you're just taking the T cells out from the graft. And it has evolved over a period of time. Initially, you used to take all the T cells out, which is called as CD3 positive T cell depletion. Then we started doing the CD3 and CD19, that is B and T cell depletion together. And now recently, we are trying to do alpha beta depletion and leaving the gamma delta cells behind and doing CD19 depletion. That means you're doing partial T cell depletion, leaving the gamma delta cells behind, which are not supposed to mediate graft versus host disease, but have anti-infective properties and help in immune reconstitution and engraftment. So that's alpha beta depletion. But then we also nowadays do alpha beta depletion with CD45 RA depletion. So this I'll explain a little bit later on, where when you do CD45 RA depletion, you're leaving behind memory T cells, which are CD45 RO cells in the graft. And these again have anti-infective properties and help with robust immune reconstitution. So these are the in vivo T cell depletion methods. What about the ex vivo T cell depletion? What about the in vivo T cell depletion? In vivo T cell depletion can be done by two different strategies. One is the Chinese strategy, where they use a lot of ATG during conditioning to do in vivo T cell depletion, and that they use for the haplotransplant settings as well. And there's the more common and the more studied and accepted way is doing allo depletion with cyclophosphamide, what we call as post-cy or post-transplant cyclophosphamide. So this is the cartoon showing exactly the same thing, how the T cell depletion has evolved over a period of time. As I said earlier, it will be initially just CD34 selection, then it has become T and B cell depletion, leaving behind stem cells and effector cells like NK cells. Now, when we do alpha beta and CD19 depletion, we are having stem cells in the graft. We are having effector cells like NK cells and gamma delta T cells. And as I said, the last one, that's T cell alpha beta and CD45 RA depletion, we're having stem cells, NK cells, gamma delta cells, as well as CD45 RO, which are the memory cells in the graft, which are going to the patient. So this has evolved, and it's very important to understand that, because the data which is there on haploidentical transplantation is going to be read in the context of what technique you have used, and that's very, very important when we interpret that data and apply that data. Now, this is a cartoon again showing the T cell alpha beta depletion for you. So this is the whole stem cell product which goes through this CleanMax device. it takes the alpha beta cells out, which gets stuck to the magnet, and then the rest of the product goes down, which is stem cells, NK cells, dendritic cells, gamma delta cells, and this is the graft, and this is given to the patient. Now, post-transfer cyclophosphamide, again, I don't need to tell this audience, very well-defined methodology on day 3 and day 4 of the transplantation. You cyclophosphamide 50 milligram per kg for two days, and what it does that it kills the alloreactive T cells, and the stem cells are spared because cyclophosphamide doesn't act on the stem cells, and hence removes alloreactive T cells. A very effective strategy of doing graft versus host disease prophylaxis in a haploidentical transplant setting. Now, getting into the core topic of thalassemia major and how this, whatever we just discussed now, can be applied in thalassemia major, and what is the data. Now, this data was showed by by Dr. Satyanan already. This is the largest Lucarelli series which they published for over 900 odd patients. They could prove over a follow-up of over 20 odd years that about 73-74% patients can be cured long term, and this is data from 1982. And so this kind of for the proof of the principle that transplant can be curative. But they also showed that transplant in thalassemia is a very heterogeneous disease, and the class 3s do not do as well, which Dr. Satyanan nicely showed, and the outcomes can be as poor as 60 to 70%. In fact, 60 odd percent in our settings from India, and what they showed here was 70-75%. And this again has been shown that when we when it was looked by Dr. Vikram Matthews at CELON, and what he showed is that class 3s in fact are two different categories, and class 3 high risk outcomes can be as low as 20%. Now, I'm trying to highlight this here. Why I put this here in the haploidentical transplant talk is because if you see here, outcomes of the class 3 as such is about 60 odd percent, and and the high risk class is the outcome as poor as 20 odd percent. But we were doing transplant for these patients also that point of time. But as we learned, where as we retrospectively looked at the data, and then we made some changes which which were like this. For example, protocol 26 adopted by the Italian group, where they introduced some preparation prior to transplantation, highlighted by Dr. Satendra already, that we could increase the outcome of these patients by around 10-15 odd percent. So the point I'm trying to make here is that it's very important to prepare the patients, and as per the risk stratification at the transplant type, to make necessary pre-transplant modifications, pre-transplant alterations or whatever additions to make the transplant more successful. And this is the data which again Dr. Satendra highlighted. This was a multi-center data which was presented a few years ago in ASH meeting, where it was again shown that using triasulfan thiatipa versus busulfan cyclophosphamide, you could see almost a 20-25% outcome difference. And again, the point I'm trying to make here is that the outcomes were as poor as 40-45% in this data series from the multi-centers from all over India. When we go to unrelated donor transplants, when we see the initial experience, which was again Italian experience by the Pizarro group, what they showed is that the event-free survival, look at the event-free survival, 21%, survival was 65%, a lot of rejections and a lot of mortality. This was the initial experience of unrelated donor transplant with thalassemia major, not very good. A few years ago, the same group published a little bit better data. The survival had gone up to about 80 odd percent, and the cure rates about 65-70%. They also showed in unrelated donor transplants that the class of disease also matters, and class 1, class 2 do better than class 3, even in class in unrelated donor transplants. But over the period of time, the outcomes in unrelated donor transplants also improved. This is the data from Thailand, where they showed excellent results with unrelated donor transplants to the tune of about 80-85% thalassemia-free survival. This is data from China, where they kind of compared this match, unrelated with matched sibling, and the outcomes were practically the same in the two groups, where they used a fully matched unrelated donor transplant and compared to the matched sibling transplant. So the point here I'm trying to make is that even in unrelated donor transplantation, the outcomes have evolved over a period of time, and now with a 10-by-10 matched donor transplantation, you expect outcomes as good and as equal to a matched sibling transplantation. But it was not the case with the first series, where the outcomes were as low as 20 odd percent. So same is the story with haploidentical transplantation in thalassemia as well. The things have evolved over a period of time, and this was the first paper which came came up in from the Lucarelli group on haploidentical transplantation thalassemia, where what they did is that they adopted the T cell depletion strategy. For few patients they used CD34 selection, but in a few other patients they used CD34 selection as well as some T cell depletion from the marrow. So you use a combination graft in some patients. But their experience, it was a good proof of principle that haploidentical transplantation can be done in thalassemia major also. So that was a plus point of the study. But as you could expect, 60% patients were cured of thalassemia, 90% survival. So there was about 30% rejection in this group of patients. So most of the patients survived, about 60% could be cured as well, but there was a very high rejection risk. And this was, as I said, a landmark study, not because the results were excellent, but because it just paved the way and set up the ground for the haploidentical transplantation in thalassemia major. Now, there were a few papers which came post that, and this was the paper from Franco Locatelli group, again from Italy, where they used the TCR alpha beta depletion, not the pan T cell depletion, but they used the TCR alpha beta depletion. And that's why I was telling you earlier, it's very important to understand the context of the data, what strategies have been adopted and what era the data belongs to. Now this was a 2014 publication, alpha beta depletion and this was not for thalassemias only. This was the non-malignant disease taken all together. And with T cell alpha beta depletion, they could demonstrate excellent cure rates to the tune of 80-85%. And this again, I kind of show the superiority of this depletion technique over the previous depletion technique. Now again, some data from Italians where they use the T cell alpha beta depletion for hemoglobinopathies, and again the outcomes had improved from the previous data set. Now the cure rates were 70% and the survival was 85% with the T cell alpha beta depletion. Still, we had about 15% graft failure even with this technique, and this continued to be a problem in the earlier data in the haploidentical transplant setting. Now, what has been our experience? This is our experience for TCR alpha beta depletion. This was our first, experience. We presented that in ASH meeting in 2017. This TCR alpha beta put all together for non-malignant patients. We had a cure rate of these about 70%. Malignant and non-malignant. Non-malignant was a little bit better, about 77%. But again, in this series, we had a little bit higher rejection rates. As it was demonstrated by the Italian group. So only 77% patients could be cured, and they about 10 to 15% rejection rate. Now, I just want to share with you a story which was a learning for us, and I think this is something which kind of also helped us a lot in modifying what we're doing. So when we started the T-cell alpha beta depletion protocol, like the Italians had, that way back in 2014, this was first case went very well. The second case is this what I'm presenting to you, 5-year-old thalassemic boy. Very intense conditioning is used under that protocol, flu-side, IoT by ATG, cyclosporin was GVG prophylaxis. We did CD4 dose. It was a T-cell alpha beta depleted transplantation. CD34 dose was about 12.7. The patient engrafted on day 13 and platelet engraftment happened on day 10. Very brisk neutrophil and platelet engraftment. This patient on day 15 started to have some fever, and we could see that gradually his neutrophil and platelet counts were dropping. Because it was particularly dropping counts, I was worried about rejection. We did a FISH study at that point of time, and that was 100% donor cells. The fever continued. He had some rash on his skin. We ended up doing a bone marrow. It showed macrophage activation syndrome with high ferritin levels and high LDH. And at this point of time, FISH was also repeated, which showed 100% donor cells. This was a marrow which was done first time, and you could see some in the left, cartoon here is that there's some HLH going on in the marrow. We started methylprednisolone inhibitor of HLH. There was transit improvement clinically, some increment in neutrophil and platelet count, but you see then his counts again started dropping and he became cytopenic. Again on day 39, we did another marrow, which again showed less cellularity but very florid HLH still in the bone marrow. So we thought it's a refractory HLH, and that's leading to these cytopenias and the fevers ongoing and we kind of increased our HLH treatment. We started ATG and dexamethasone. The child on day 49 had respiratory distress, desaturation, X-ray showed ARDS. This time when we repeat the FISH, it showed 85% donor cells. We tried to give autologous stem cells to this patient, but there was prolonged neutropenia and neutropenic sepsis, and the patient succumbed to this. And just before the death of this patient, we had taken a sample again for chimerism, and that chimerism showed. And this was his last marrow before death. It shows very, very hypocellular marrow. Now, HLH activity has also come down, and his chimerism had dropped down to less than 5%. So this was basically a case of rejection, which had manifested itself as a haplostorm. And that time we were not very, kind of familiar with this entity. The second case, which was followed, that had almost a similar picture, he had HLH in his marrow, but this time we're a little bit, kind of prepared for this, a little smarter, I would say. We salvaged this patient by autologous stem cells, and we had to stop with haploidentical transplant for thalassemia, and that time on this is 2014. But at the same time, we didn't see this phenomenon of haplostorms and rejections manifesting as HLH happening in malignant transplants. So malignant transplant program continued, and we used the T-cell alpha beta depletion for them, but we didn't see this approach. So then we thought there's something different, which is in the two. And one of the differences is that the patients with leukemias and malignancies are immunocompromised when we start transplantation. So we started this protocol where we used a pre-transplant immunosuppression strategy in these patients who are undergoing haplotransplants for thalassemia. So what was this protocol is that the idea was to, avoid this haplostorm happening and the rejection happening in the form of haplostorm. And we used this pre-transplant immunosuppression strategy of cyclophosphamide, fludarabine, and dexamethasone. We gave that fludara for 5 days, dexa for 5 days, and cyclophosphamide day 1. Every 15 days, we did it for 3 times. And then after that, we would let them recover, admit for conditioning, post that. And we were surprised with the results. So we had this broad group of patients. Majority of the patients had haplotransplantation with alpha beta depletion, but some patients did also have post-transplant cyclophosphamide as a GVHD strategy. And 15 odd patients. This is a few years ago when we presented it. That time we had about 15 odd patients with this. Majority of these patients being class 1 or class 2 patients. And what we saw is that conditioning was myeloablative in all these patients. Based on flu cyclophosphamide, and some patients received ATG, and some patients with TBI conditioning. And the patients who had T-cell alpha beta depleted transplant, we tried to use mega doses of CD34, and 16.6 was the median dose of CD34. T-cell replete transplant, that's post-transplant cyclophosphamides, it was the median dose of about 5 million per kg. And to our surprise, all these patients engrafted. 15 out of 15 patients engrafted. There was acceptable graft versus host disease. No major problem except for a little bit higher risk of dark, CMV attenuation, which we would expect in a haploidentical transplantation setting. And all the patients, all the patients except for one were cured as well as alive. So there was a survival of about 92%, both thalassemia-free survival as well as overall survival. One patient died with adenoviral infection, and there was only mortality in this group. So this was a small cohort of patients, and in fact now we have, with this technique, more than 50 patients who have had pre-transplant immunosuppression with thalassemia major and haploidentical transplantation, and these results which still hold the same as they were at that small group of patients of 15 patients. So what it showed is that with this pre-transplant immunosuppression in a haploidentical transplant setting, it is well tolerated. It can lead to sustained engraftment and low rejection rates, and can lead to improved disease survival. So this history was important because it helped us to understand how we can deal with these patients. Those who have got very high rejection rates with haploidentical transplant setting. Now, similar kind of strategy. This is now a paper from Thailand. What we call as famously called as Thai protocol, where they use a similar strategy, although they didn't use cyclophosphamide, which we have used in our study. We were not aware of this data, in fact, when we started that in 2015, and this kind of came after that. This was fludarabine dexamethasone, 2 cycles, followed by a conditioning which was based on ATG, fludarabine, busulfan, and post-transplant cyclophosphamide. So they had used in all the patients post-transplant cyclophosphamide. The initial data, which was presented as an abstract, was about 15 odd patients. 14 had successful engraftment, and only 1 patient rejected out of these. So, mind you, we are talking about haploidentical transplantation in a thalassemia major. 1 rejection out of 15 is excellent. This data was again presented, and published later on, and this They had added more patients. I think the paper which was published later on had more than 30 patients, and this data was holding true with overall survival and event-free survival of about 94, 95 patients in the haploidentical transplant setting. So just by introducing one concept of pre-transplant immunosuppression, both in our experience and the experience which the Thai group has shown, the outcomes could be made to the tune of 90% which is almost as good as a patient with MAT sibling donor transplantation. Now, the second question which comes in the mind, I think, I think there's a debate which goes on, is haploidentical transplantation experimental in thalassemia? Is haploidentical transplantation something which can be offered in thalassemia? I think, I try to look at this, and there are a couple of, I would say, guidelines which are available. One guideline is from the European Society for Bone Marrow Transplantation, EBMT. There's also guideline from NHS, and what they both say, and if you see this, there's a recommendation here. This is from the EBMT. They say alternative donor or haploidentical transplantation is basically a clinical option, and that same degree of recommendation is kind of applicable for unrelated donor transplantation as well. Only a MAT sibling donor transplant, as per EBMT recommendation, was published 2015, is a standard of care. But unrelated donor transplant and alternative donor transplantation or haploidentical transplantation is a clinical option, so can be offered as a treatment option. This is basically the recommendation from our NHS, and they also, for haploidentical transplantation with thalassemia major, as well as for unrelated donor transplantation, it's again is kind of put here as a clinical option. So of course, in thalassemia major, transplant is always an option. I would say even MAT sibling is an option, because it's if family chooses to take a transplant as a curative intention, then it can be offered to them. But patients can have an excellent quality of life with blood transfusions and good chelation, with good quality of blood. So it's always an option, I personally feel, and if you go at the guidelines, it doesn't anyway say it's it's experimental now. I think we have got enough data now, which I showed you, that it can be offered, and the outcomes have really improved in the recent times, and the recent outcomes are in the range of 85 to 90%. Now, what happens, in the context of the neutrophil engraftment? I think this is one of the, just put a couple of slides, how we compare the two. This is our experience, our center, because we had done almost equal amount of T-cell depletion and post-transplant cyclophosphamide transplants. And we have seen that in T-cell depleted transplantation, the neutrophil engraftment is quite brisk. It's about 10-12 days they engraft, and which is delayed by a few days in post-transplant cyclophosphamide, and we all know how important that is in the context of our country. We also see a better and brisk platelet engraftment versus PTCY, because the cell doses used here are quite high, the stem cell doses, and that's statistically significant as well. The second question, which is always asked about immune recovery. We all know that immune recovery post-haploidentical transplantations are poor as compared to a MAT sibling transplant, and also to an extent as compared to unrelated donor transplant, a fully matched donor transplant. So we did some work about immune recovery at various time points, which I mentioned here. And this is the immune reconstitution of depleted transplantations. ALCs, lymphocyte count, NK cell, and CD4 count at 21 days, 3 months, and 6 months post-transplantation. If you see at 6 months, they're relatively in a reasonable good numbers, although still low, but then there's a reasonable recovery of all the immune cells by about 6 months post-transplantation. We try to also compare the post-transplant cyclophosphamide with T-cell alpha-beta depleted transplantation. If you see ALCs here, by 3 months, they're almost same. Although at 3 months, the PTCY group, the ALC recovery is a little bit faster. NK cells, we know that NK cell recovery is very, very brisk, very, very fast in T-cell alpha-beta cells. And this is very important earlier in the transplant, especially malignant transplants where you can mediate graft versus leukemia effect. And by 3 months and 6 months, they are both comparable, and that's the case with CD3, CD4, CD8, as well as CD20 cells. That usually, by 3 months and 6 months, they kind of are both comparable. So I think from the immune recovery point of view, I don't think there's much difference in the two groups, T-cell alpha beta as well as the post-transplant cyclophosphamide. Now coming to the last kid on the block, which is the alpha beta and CD44 RA depletion. What you do is that you do T-cell alpha beta depletion on one fraction of the cells, and then they take a small proportion of cells where you do CD45 RA depletion, because you leave the CD45 RO which are the memory cells in the graft for the infusion. So you infuse basically two allocates. One is for the T cell alpha beta, and then one is for the CD45RO infusion. Now, what are these? These are memory cells, and what happens? These memory cells can be given by two different approaches. One is that at the time of transplantation, you can give them. You can give them at day 0 along with the graft, or we can also give them a little later on. We can give T cell alpha beta depleted cells here, and we can give these CD45RA depleted, which are the CD45RO cells here as a DLI, which can be given a month post-transplantation as a DLI strategy. Now, both have got their pros and cons, but what is very important with this strategy is that this helps you to give a large number of memory T cells along with the graft or later on, and which helps in rapid immune recovery, reduces the chances of viremia, enhances T cell recovery, helps with engraftment and better immune reconstruction, and probably helps in the less viral infections also. We have been doing this for the last couple of years now. May 2018, we started T cell alpha beta CD45RA depletion. 18 patients of thalassemia have had this transplant, and as I said earlier on, we use PTIS, post-transplant immunosuppression, for all the patients of haploidentical transplantation in thalassemia now. And we found that with this depletion, we get a profound depletion of both CD45RA and T cell alpha beta depletion with Clinimax device. It's very feasible, well-tolerated procedure. Out of these patients, 18 patients, 17 are alive, 16 are cured of the disease, and everyone engrafted. There has been no acute GVHD, and the incidence of viremia has also significantly come down. So I think we need definitely more number of patients, but I personally feel that giving this memory T cells back does help, in the better immune reconstruction infections. For the want of time, I'm not going to discuss all this here, but then in the haploidentical transplantation setting in thalassemia, there are various other considerations to be kept in mind. Donor selection: who's going to be the donor? Mother, father, sibling. That's something is by itself a big topic. Role of donor-specific antibodies and desensitization is. I think there's a question in the chat box which I thought we'll discuss later on. This again very important in the donor selection. Appropriate conditioning. I think Dr. Satendra nicely highlighted it. So it's very important to understand what kind of conditioning tailored to the patient's age, risk stratification, and also type of transplantation. We need to tailor it according to the transplant type we're offering. There's a problem of rejection and mixed chimerism, and that's more in the haploidentical transplantation setting, and that's something we need to keep in mind. And hence, post-transplant, pre-transplant immunosuppression, which was alluding to earlier, is an important aspect to help curtailing the rejection. Post-transplant immune reconstitution is going to be definitely poor and delayed, so we need to be prepared with that. Viral infections are going to be a problem. And as very important is that counseling and understanding the family, the whole process is very, very important, because the long haul, it's not like math subjects. You reduce your guard after 3 months post transplantation, but haplotransplant setting, your intense guard, follow up, and all that has to be conducted for at least 6 months post transplantation. And of course, financial concerns. These are more expensive transplantation. That is something which we need to keep in mind. So to summarize, this is my last slide. Haplotransplantation, either with T cell depletion or with post-transplant cyclophosphamide, is effective alternate to those patients who do not have a matched sibling or unrelated donor transplantation. Newer strategies of depletion like this T cell alpha beta CD45RA may improve outcomes. I think we need to have more data on this. Post-transplant immunosuppression seems to be an important element in managing these transplants. So I think whosoever of us embarks on a haplotransplant in thalassemia, I think this is a very important component of the preparation of these patients prior to transplantation. Careful selection of condition is very, very important. Post-transplant immune reconstitution and viral infections are still a very big concern, and that needs a very close follow-up and management. And the last but not the least, these are a learning curve, and these transplants are evolving. We're learning with every patient, and there's a learning curve in handling these transplants, which I think we need to keep in mind. With that, I thank you, and I thank you for your attention, and I think I'll see if any questions are there before we move on to the next slide, the next presentation. Now, I'm not able to. Can the organizer stop my screen share? I'm not able to stop this screen share, unfortunately. I don't know why.
Yes, sir.
Yeah, please do that. So I'll just have a look at the Q&A. If there's anything burning questions to be asked, then we can do that. Okay, so there's a question that what are the dose of CD34 in TCR depleted transplants which we use. So Chintan, we had done this. I didn't put that data here. We divided our cohort into 3 groups. Less than 10, 10 to 20, and more than 20. So to be honest with you, we didn't see any difference in more than 20 in the stem cell dose more than 20. So more than 20, in fact, we saw, as you rightly pointed out here, there was a little bit more CRS and also more GVHD. Although it was lower grade GVHD, but it was more. So we have stuck ourselves to keep it less, between 10 to 20 and closer to 10, because that hasn't really shown any greater benefit than making it more than 20. Now, the other question is about. Okay, so the other question is what percentage of rejection can be reduced with this approach? So I think, Dr. Gagandeep, we have basically the whatever little data I showed you from Thailand and from our own experience. The rejection rates with post-transplant immunosuppression, pre-transplant immunosuppression, where they have been employed, has come to less than 5%, which was almost 30-odd% with the initial data when the PTIS was not used. So I think with PTIS, pre-transplant immunosuppression, the rejection rates in haploidentical transplantation setting can be reduced to less than 5%. But of course, that is all in the background of when you have done the proper donor selection, you have taken care of the donor-specific antibodies, taken the those donors who don't have against which you don't have donor-specific antibodies. I think then it's relevant in that case. I think I'll stop because I'm going to encroach onto the last session. And with that, we go to the last session from today, which is a panel discussion. And I think it's a very important session, probably the most important session for today. And that is what are the complications which we see in transplants in thalassemia major. And I think we're all aware that there are some unique complications which we come across in thalassemia transplantation. I think Dr. Gaurav is going to be doing that. Dr. Gaurav is a clinical lead and senior consultant pediatric hematology oncology at Apollo Hospitals in Delhi. And we have a very esteemed faculty today. Our teacher, some of us on the panel, Dr. S.P. Yadav, who is the director of pediatric hematology oncology at the Medanta, Delhi. Dr. Ruchira Mishra, who is a senior consultant at SRCC and Narayana Health Hospital in Mumbai. We have Dr. Anupam Chakrapani, who is a senior consultant pediatric hematology at Apollo, Calcutta. We have got Dr. Ganesh, who is a friend, a senior consultant head of hematology from Yashoda Hospitals in Hyderabad, and Dr. Shantanu Sen, a senior consultant head of pediatric hematology oncology from Kokla Bank in Mumbai. So a very esteemed faculty and great experts in the field. Gaurav is going to take us through some of these questions which are really relevant in thalassemia transplants. Over to you, Gaurav. Gaurav, can you hear us?
Gaurav sir, we can't hear you. Hello?
Is he muted or?
No sir, he is not muted.
Okay.
Sir, can you check the volume of your system?
गौरव क्या प्रॉब्लम हो रहा है? So can anyone from the mice help Gaurav to log in? Then we can take a couple of questions in the meantime.
Okay, sir. Sure.
Yeah, just help him to relog probably. He's not, audio is a problem, I think. We can see him, I can talk to him on the phone.
Okay, sir.
So I think I'll ask some questions from the chat box to the experts in the meantime. Dr. Yadav sir, are you there?
Yeah, Sunil, I'm there.
So there's a question which I thought, maybe Gaurav will cover, but we can do it in the meantime. And that was on donor-specific antibodies. So there are a few questions, but I just consolidate all of them together. One is that what methodology we should use for donor-specific antibodies.
Mhm.
Number two is that against what all, antigens/alleles you'll check the donor-specific antibodies. And what the third question is that what would be a significant titer in your experience?
So at present, like donor-specific antibody in haplotransplant is a must to be checked before taking up a patient for transplant, especially in non-malignant conditions, because the risk of rejection is quite high in these patients. They have a very immunocompetent marrow or very hyperactive marrow, and they can reject the donor cells pretty quickly. In patients with leukemia, they have been heavily pretreated with chemotherapy. So in them, it's not that much a problem. So in thalassemia, particularly when you're choosing a donor, the patient should not have donor-specific antibodies. That's the best case scenario for that particular donor. And if there is no donor available, like if all the donors have antibodies present, then you should look at the one who has the least level of antibodies. So the cutoff most people consider is about 3000 MFI. That once the antibodies are more than that, then that's a bigger problem. Then if it's less than that, then those donors can particularly be considered. And but still, if the antibodies are present, you have to treat them and try to reduce them to as low as possible before taking up for transplant with that particular donor. In antibodies, one is you are checking for against each HLA, the antibodies of the patient, of the donor. A patient has the antibodies against each HLA. And HLA-DP, we are not checking these days as yet in my center. I don't know about other centers, but HLA-A, B, C, DR, DQ, we are checking. And then the antibodies against complement should also be checked. And but that's not easily available. But I think Lal Lab is going to set up or has set up. I'm not doing it in my clinical practice as yet, but that's something recommended that we should do. So that's about the antibodies part, and it's important. Over to Sunil. Yeah.
Gaurav, can you hear us now? Thank you, sir. Gaurav, can you hear us?
I think there is some problem with Gaurav's.
Gaurav's audio is a problem.
Maybe he can log in from his phone on Zoom, and we can.
Someone from MICE, please sort that out. I will continue with the next questions. So
this whole complement, the antibodies complement is probably the most important into the anti-cell antibodies, and Dr. Lal Path Lab is about to roll out the availability maybe in the next 6 to 8 weeks. I think this whole corona thing has delayed it, but by the next year it will be available, and this is the one which actually will tell that what this antibody is likely to do ultimately in the patient. It's very, very important, and Dr. Lal Path Lab is going to have this, and that will be available for the whole country because Dr. Lal Path Lab is everywhere. So that's good news for all of us, and they're going to.
Dr. Ganesh, are you there?
Ganesh is on mute. He has to unmute himself.
Please unmute, Dr.
Yes, sir.
Dr. Ganesh, a question which has again been asked is about, ethical, I would say, ethical discussions, ethical concerns in regards to thalassemia transplant. Not only in the haploidentical transplant setting, but also in the setting of siblings being donors, small siblings, weight discrepancies and all that. So how do we deal with that?
Thank you, Dr. Sunil. First of all, I would like to congratulate both the eminent speakers, Dr. Satyendra and Dr. Sunil, for such a wonderful, presentation and talk. Has been always a, lot of learning through your deliberations. Regarding the use of haploidentical transplant across not only the malignant indications but non-malignant indications, as Dr. Satyendra has nicely elaborated in his talk, and Dr. Sunil has, reciprocated and also shared his experience of newer techniques, pre-transplant immunosuppression, and the conditioning, modulation, and post-transplant immunosuppression or GVH prophylaxis modulation. So the outcome, if you see the recent literature for last maybe 5-7 years, the outcomes of the alternative donor transplants, including the haploidentical transplants across different non-malignant indications, is at par with the match sibling transplants. And without the transplant, the outcome of these children, particularly the pediatric population, is dismal. The Satyendra has nicely highlighted in his in his presentation and his slide set that the overall survival was around 20 years or less in the thalassemia major. And recently, I'm not talking about just in India but across the globe, the most developed countries where the the conventional non-transplant care, including regular transfusions, iron chelations, which is the optimal thalassemia care for that matter. Despite that, the long term, the overall survival hardly is second or third decade. So compared to that, the transplant is the only therapeutic option which offers
is it okay?
The curative potential in these
Sorry, am I audible now?
You're audible, Gaurav. Just 2 minutes.
But I can't hear you people. Hello?
You're audible, Gaurav. Can you not hear
Sunil,
us?
I can't hear you now.
Gaurav, you check your Bluetooth connections.
I don't know. Probably you can hear me, but I can't hear you now.
Okay, so we'll carry on with the discussion. Mice, please carry on with your back and work with Gaurav. So I think we're going on with the thing. Yeah, Dr. Ganesh, sorry, we got interrupted. Huh?
Yeah, so this is the most important message for that matter. I just half an hour back I was going through the literature. Even today, just a June 2020 publication by the American and the European collaborative group on the various ways to modulate haploidentical or alternative donor transplant in children with thalassemia major in the countries where thalassemia care is absolutely optimized. It's not like, I'm sure all of us, the eminent panelists, the eminent speakers and eminent teachers on this platform will agree with me. Out of 100, not even 5% thalassemia major children in our country gets the optimal thalassemia care. Compared to that, even in the developed nations like the Western countries like North America or Europe or Australia, whatever it is, just a recent publication, June 2020, BBMT, Biology of Blood and Marrow Transplant, modulating trying to modify the protocol, conditioning, pre-transplant immunosuppression, post-transplant GVH prophylaxis. The outcomes are at par with match sibling transplants, and that's the key message. If you want the children to be completely thalassemia free, leading a meaningful life with a reasonable life expectancy, I think this is the future, and we have eminent transplanters on a national platform. Yeah, Satyendra, I can see your.
I just want to add one question, So rather than asking this question from that side of the table, I want to ask the people onto that side of the table that not offering a cure in a country where patients are not getting the standard of supportive care and giving them, let us assume that even in India, the match sibling transplants are low risk are 85 to 90%, and the high risk are 70%, and the haplotransplant are producing 70%. Now, you want to play the god, and you don't want to give the chance of cure to these patients. Is that ethical? If a family wants to take that call, that no, I want my child to live a normal, meaningful, happy life, and I want this transplant, and denying them the transplant, is that ethical? That is not ethical, right? So whatever cure is there, if the family wants, if it is not experimental, should be given to them. And this is not an experimental treatment. Now, I have heard a few talks now recently that even for match sibling, there are few people who will stand into a meeting and they will ask a question. Should we have a match sibling transplant also for the thalassemia patient, when we are seeing that the thalassemia patients are going to become the pilot also, this doctor also, and all that? Come on, guys, start. That's not the truth. Only 2% of the thalassemics are getting into the third decade in our country, right? So taking the survival data from the Western world, and then guiding our patient that, let us assume that the supportive care is of the Western, that's absolutely double standard of us, right? We do not give better supportive care, and whatever good available is the cure, and that should be offered. That's what I want to say.
Point taken, Sajid. I think it's a complex discussion. It needs to be discussed with the family.
Dr. Sunil,
Oh, hello.
30 seconds.
Am I audible now?
Before we go to the discussion, I just wanted to another important, because this is an August audience, who, the pediatricians, the physicians, the message has to be clear and precise. See, every transplant, Satyendra and Sunil have nicely elaborated in their, deliberation that, in transplant, now we see this figure, Professor Donald Thomas, the father of transplant across the globe. So transplant is a learning curve, even for match sibling transplant in the era 60s, 70s, 80s, the long-term survival, post-transplant survival used to be 20, 30, 15, 20, 30%. The same is true for the haploidentical transplant also. Even for malignant indications where it's a desperate situation, the survival used to be 10, 20, 30. But now, with the learning curve, the survival is 50, 60. So for every disease, the learning curve, unless and until we keep on learning and keep on, continuing with the whatever is the, science or literature-based, evidence-based practice, we won't be able to succeed in clinical practice, even for, across, benign as well as malignant hematological indications, including thalassemia. Thank you.
Thank you, Ganesh. So, are you able to run your presentation now, Gaurav?
Yes. I mean, the presentation was there, but can you hear me now?
Yes, we can hear you.
Sorry. I'm extremely sorry. God knows, despite being on this for so long, I mean, these technical
Right. So please
happening.
start, but we have only 20 minutes to wind up.
So, as Sunil and Satyendra has very nicely, they've highlighted what progress has been made in transplants for thalassemia. Along with these transplants, there are a lot of challenges that come up. So I'll just brisk you through the initial slide, which is about transplant. And I think the next thing has also been covered by both Sunil and Satyendra, which highlight the progress which has been made. Both this Pesaro group and Pescara group showing their experience of almost 900 patients and 25 patients with excellent survival, which dates back from 1981 till roughly around 2000. This is the transplant from EBMT database on thalassemia from close to 120 centers. But this is old data till 2006. So many transplants have happened, and a lot of unrelated donor and haploidentical transplants have also taken place thereafter. So what is the current status for transfusion-dependent thalassemia with the progress which has been made in the conditioning, IV busulfan, targeted BU levels? This all has been highlighted by Satyendra and Sunil.
coming up of drugs like thiatipa, triosulfan, fludarabine. So all these things have led to a significant change in the outcome of transfusion-dependent thalassemia. Okay.
Good, good, good. Boliye, sir.
Hello.
Climate is very comfortable.
Hello. So what changed in between? So basically, better patient selection and pre-transplant preparation, as very nicely highlighted by Dr. Sunil, that the pre-transplant preparation plays a very important role, especially in alternative donor settings, and maybe this has a role to play in match sibling and match related donor setting also. And we have a very small study based on this particular thing, which shows that the outcome of even unrelated donor transplants can be significantly improved by offering this pre-transplant preparatory strategy. Better understanding of transplant immunology, increasing donor options in the form of mud and haploidentical donors. So all this has led to significant change. But with this change, there are a lot of complications, and we'll just brisk through the complications. Sunil has already introduced the esteemed panelist with us today. So we will ask our queries from them. So this is the transplant timeline. And my understanding about the complications and where to place these complications, this is how I see it. So transplant during conditioning phase, transplant during immediate post-transplant phase, which is day 0 to day 27, post-transplant day 28 to 100, and thereafter. So this is how I try to divide the classifications and look at them. When we talk about classifications, we can also consider them based on the conditioning received, whether it is myeloablative, serotherapy, what kind of serotherapy, how intense, what dose, what are the patient characteristics. So transplanting a 5-year-old thalassemic is not same as transplanting a 15-year-old thalassemic. As Satyendra and Sunil have highlighted, match sibling donor, match related donor, and haploidentical donor all have different considerations, and different things need to be kept in mind. GVHD prophylaxis strategy, and based on all these things, how well prepared we are for our transplant. So this is what decides the outcome of transplant in today's scenario. So we will go through this one by one. First of all, talking about the conditioning. So what is the preferred choice of conditioning chemotherapy for match sibling donor, and why? This question is for Dr. Yadav, sir. So in current scenario, I know Satyendra and Sunil have already discussed, but what will be your current choice of chemotherapy for match sibling donor setting?
Okay, thank you, Gaurav. So we don't have much time, so I'll try to be quick. So conventionally, busulfan cyclophosphamide has been used as a conditioning in thalassemia, but there is a problem in class 3 patients with higher mortality with this particular conditioning regimen, with a higher risk of veno-occlusive disease. So nowadays, people have moved to triosulfan, thiatipa, and fludarabine-based regimen, which is much safer and has less risk of VOD, especially in class 3 patients. So my quick answer is that triosulfan-based conditioning is preferred conditioning these days, especially in class 3 patients. In very young patients, busulfan cyclophosphamide is still a good option. Thank you.
So thank you, sir. If Dr. Ruchira may allow me, I'll skip this question because of lack of time, because it has also been covered by Dr. Satyendra and Dr. Sunil about the previous conditionings. Now the dictum is very clear that if all the factors, I mean the financial considerations are not there, the preferred choice is thiatipa, triosulfan, fludarabine. Graft failure and mixed chimerism are a significant concern with RTC. So what is are they a significant concern, or it was just a thought in the initial years and now it has changed? Hello, Dr. Shantanu, are you there?
Oh, hi, sorry. I might cut in and out a little bit, so apologies in advance for that. Thanks for inviting me. I won't switch on my video, but fantastic presentations from both the presenters. So answering the question, is graft failure a concern? It definitely is still a concern when you're dealing with thalassemia. Slipping chimerism remains a huge concern. Because if you think there are two things, if you're only talking about thalassemia, and we see that the chimerism is slipping, it's reducing as we see, we get seriously worried. Because if that happens, then we are kind of between the devil and the deep blue sea. What do you do about it? You reduce immunosuppression, but the main question that comes through is, would a transplanter be brave enough to think of doing a DLI. The problem is that if you do a DLI, you might be able to shore up your graft, but what you are buying also together with it is the chance that you might be pushing your patient into GVHD, and that's certainly something we take great pains to avoid. So in a nutshell, yes, we are worried about it. What can we do to avoid it? Better conditioning protocols and hopefully better anti-GVHD prophylaxis, and we hope for the best.
Right. So thank you, Dr. Shantanu. So graft failure, yes, it remains a concern, but as we learn more and more about transplants, how it works, the focus has now very clearly shifted from a myeloablative condition to reduced toxicity conditioning. There's a lot of focus on how well you prepare a patient, and this is what decides the outcomes. The graft failure in mixed chimerism has decreased significantly. As Sunil has highlighted, it is less than 5%, even in haploidentical settings. In our cohort, in sicklers, it is almost zero in even in haploidentical transplants. So with the better understanding of transplants, these things have been taken care of in a great extent. And this is a paper which was published by the Italian group, or the initial results on the triosulfan based conditioning, and fantastic results, very nicely covered by Satyendra in his presentation. So I'll skip through this, but yes, reduced toxicity conditioning, or some, as they say, reduced intensity conditioning using thiotepar, triosulfan, fludarabine is the standard of care for a matched sibling donor thalassemia transplant nowadays. Moving on, TTF. So anticipated problems and your preparedness. So even considering this to be a reduced toxicity conditioning, still there are some problems. So what should we be watchful of while administering thiotepar, Dr. Ganesh?
So basically, thiotepar, because of its very good favorable toxicity profile and better immunosuppressive as well as myelosuppressive properties, it's being used quite commonly in combination with the myeloablative or reduced toxicity conditionings. So the most important thing is it's because of its skin toxicity. The administration should be 0.5 to 1 mg per ml. The dose is less than 200 mg. It can be given in 250 200 ml NS, or the dose is more than 200, so it should be given 500 ml NS, or if the dose is more than 500, should be given in 1 liter. And the reconstituted solution can be used up to 24 hours. So the dose is 5 mg per kg, either 12-hourly or on 2 consecutive days. And the patient should be asked to take bath twice daily, at least 48 hours after the thiotepar administration. Of course, even though thiotepar is a bi-alkylating agent, the administration has not shown much higher incidence of veno-occlusive disease across the various malignant as well as non-malignant indications. But the appropriate precautions should be administered.
Yeah, so thank you, Dr. Ganesh, and your background is as learned as you are. So very nice background, a lot of books there. What complications to look for while administering triosulfan, especially in younger kids, Dr. Anupam?
Yeah, thanks, Dr. Gaurav. So this session started with a question, what is the best regimen? And I think we all understand that triosulfan is the drug which has changed our thalassemia transplant outcome. So one should be very careful in terms when we are using triosulfan in terms of immediate complications, and the late complications should also be kept in mind. So like skin rash, exfoliation, and sometimes you will get a complication like alveolitis after some time, and a very long-term complications. Some patient develops pulmonary fibrosis as well with triosulfan. And some side effects like which was documented with busulfan, like veno-occlusive disease is also happens with triosulfan, and some long-term side effect like cardiomyopathy. So though this drug has changed our thinking in terms of outcome, but we should not be relaxing while administering this drug, and we should be watchful for the immediate and long-term complication for this drug.
So yeah, thank you, Dr. Anupam. So main things to look for is like, yes, the incidence of sinusoidal obstruction syndrome, BOD, is less, but yes, we cannot completely ignore it, especially in kids who are younger. Sinusoidal obstruction syndrome. There is a similar kind of thing which happens in the lungs also, which is called as pulmonary VOD, although rare, but whenever it happens, it is very, very significant. We have seen it in 2 of our patients, not thalassemia, but other inherited marrow failure states, and it is really a challenging scenario. And CNS toxicity, where the kids are predisposed for seizures when they receive triosulfan. So these are the things which we need to look for. Any comments on or personal experience about fludarabine toxicity, Dr. Ruchira?
Dr. Gaurav, I personally haven't had any experience of toxicity to fludarabine with our cohort of patients that we've treated with fludarabine. But yes, people do talk about CNS toxicity, which needs to be watched for in these patients. Some of times it may be presenting as confusions, hallucinations, or even coma in these patients.
So
personally haven't had an experience.
Very true. It's a rare complication, fludarabine related neurotoxicity, but whenever it happens, the dictum is that you should not re-challenge that patient for a second course. So fludarabine is in use for pre-transplant immunosuppression, and then during the conditioning for alternative donor transplant. But if there is a single episode of CNS neurotoxicity with fludarabine, then a second challenge should not be given, okay? Because it is the second, you might not get a second chance that with fludarabine related CNS toxicity. So moving on to alternative donors, again, this has been covered partly by Satinder and Sunil. What you would like to do? Would you like to do anything differently in cases of matched unrelated donor with peripheral blood as source, Dr. Shantanu? This conditioning is fine. I'm specially focusing on the serotherapy. Anything different or any different pre-transplant preparation whenever you have, because majority of our donors, whenever they get an unrelated donor for our patients, majority of times, as we see, we get a peripheral blood as a source. So would you do something differently? Dr. Shantanu? I think he's not there.
Sorry, I missed the question. Can you just repeat that?
Dr. Shantanu, if you have a matched unrelated donor with peripheral blood as a source, unrelated donor we are talking about, would you like to make any changes in your conditioning strategy or your serotherapy?
Okay, so basically, if you are using a peripheral blood, what we obviously have, we have more mature cells that are coming in compared to if you were to use a marrow as a donor, which means, and this is something we know, that whenever you're doing a transplant with a peripheral blood as a source, your chances of your rates of getting GVHD would be slightly higher. So in which case, these are the cases which would benefit from using serotherapy, whether you use ATG or CAMPAT, something to actually take off some of the T lymphocytes. So that would be the main change in protocol that needs to be done compared to peripheral blood as compared to marrow when you're doing a MUD.
Sure.
Just a comment there, because we've got a lot of students also logged in. Is that there is something, a concept of proximal and distal ATG. Proximal is very, very away from the graft, whatever kind of definitions you make, and the ATG closer to the graft. So in a PBSC graft, we'll try to make ATG closer to the graft so that there's residual activity against the donor mature T lymphocytes. And a marrow graft is a little bit more proximal to take care of the rejection, not for the GVHD. So that may be a little bit alteration we'll do in the conditioning.
Other thing which might be considered is changing the serotherapy from so CAMPAT is a challenging drug. It is not available and it comes with a lot of viral reactivations. If we have to choose with the ATG, then we might consider using rabbit ATG in this setting, because the chances of graft versus host disease, which will be a concern with MUD donors, especially with peripheral blood as a source, might be a little bit less. All right. So this is about the MUD donor setting. What complications are expected if we are dealing with a haploidentical donor? Sunil has highlighted it. Graft failure was a significant problem, which has been addressed very nicely by using pre-transplant immunosuppression. Anything else, Dr. Yadav, sir?
So haplotransplant in particular, when we are doing, so as you have highlighted, that graft rejection or poor graft function can be one of the big problems. But other than that, there can be hemorrhagic cystitis, which we commonly see in other haplo settings also. And BK virus reactivation is a common problem which we should be prepared for. There is something known as engraftment syndrome, so that we have to look out for. And there is around day 14, 15, other than the engraftment syndrome, if the child has gram-negative sepsis, it becomes a dual problem with engraftment syndrome causing capillary leak and gram-negative sepsis also causing capillary leak, and these patients go in shock and land up in ICU. So prevention of infection and early management of sepsis is important. And then comes your the usual risk of acute graft versus host disease and chronic graft versus host disease in haplo. That's also very much a risk. And VOD is a risk in thalassemia, even in haplo PTCY. So you have to watch out for that. And thrombotic microangiopathy is another real problem that we have to watch out for. Thank you.
Yeah, thank you, sir. Thank you. I mean, this last question is not that relevant because I doubt how many cord blood transplants are done nowadays, but just for the sake of completion of alternative donors, what is your take on related cord blood transplants for thalassemia major in Indian scenario, Dr. Ruchira?
So cord blood transplants are definitely taking a second place in the Indian context. What we are worried about cord blood transplants is the long time they take for engraftment. So prolonged hospitalizations is the biggest challenge that we face with these patients. Though there is a theoretically decreased risk of GVHD in our cord blood transplant patients. With related cord blood transplants, I personally would rather wait till the donor is a little older and then can donate fresh stem cells to us rather than using a cord blood unit. One, because the number of cells that we get, stem cells that we get with cord blood is always doubtful, considering that the cryopreservation may or may not be up to standard. So that is my take on that.
True. Yeah. So I totally agree with you, Dr. Ruchira. So things are different in this part of the world as compared to the European and American scenario. So there, the Lucarelli and group very beautifully demonstrated that the outcome of related cord blood transplant is as good as matched sibling donor transplant, but somehow we have not been able to reciprocate this. And for our for Indian scenario, somehow cord blood taking is sort of going down, and haploidentical
So,
transplant.
Gaurav, can I just add a comment on this?
Yes, sir.
So,
yes, sir.
In India, because of our cord blood banking, that's the big issue, that we are not sure that after thawing will we get enough stem cells or not. And that's why we prefer to do a combined transplant with the peripheral blood or bone marrow and cord. And we have done 5 such cases. And the good thing was that there was hardly any GVHD. So chronic GVHD was much, much less in these patients. So adding cord blood possibly reduces GVHD. That's what I would say. Thank you.
Yes, sir. Yes, sir. So a top-up transplant.
So Gaurav, no. So there is
combination transplant is. Yes,
so
yes, Satendra.
There is a very, very significant paper just 1.5 years ago from USA. There is a combined transplant from cord with haplo in thalassemics, and they have produced 100% survivals. So it's just the how do you do, and the GVH and everything, and engraftment was taken care by the cord and everything. So they have put their own way. So how do you expand the cord? How good your banks are? Ultimately, that is the game, because the engraftment they have sorted out by the combination and all that. So cord is no doubt. That's a difficult thing for us, primarily because of our infrastructure. But cord is there, and probably one day we will also be using it.
Okay, thank you, Dr. Satendra. Moving on to serotherapy, so which is a very important aspect. First of all, I would ask Dr. Yadav that do you what will be your preferred choice? So if you have an option with along with tiotepa, treosulfan, fludarabine, would you be comfortable adding ATG in a matched sibling donor setting or not? So this is a big question, because many people just go with TTF without using ATG for haplo for matched sibling donor thalassemia transplant as well. So I would like to have your take on that.
Gaurav. My quick answer is that I always prefer to use ATG in thalassemia transplants along with even in matched sibling conditioning, and that reduces the risk of rejection as well as it reduces the risk of chronic GVHD, which both we don't want. Thank you.
Yeah. So it is clear that ATG should be used even if it is a match sibling or a match-related donor transplant. Preferred serotherapy for match sibling donor, Dr. Ganesh?
So, first of all, I should confess my experience for match unrelated or alternative donor transplants for thalassemia major is almost zero. So whatever I I had gained the whatever little that is through all of the experts in thalassemia alternative donor transplants across the country, Dr. Satya Yadav sir, Satyendra Katewa, Sunil Bhatt, and Gaurav Kharia. So with regard to match sibling donor transplants, with the advent of this novel conditioning with triosulfan thiotepa, particularly thiotepa having the equal immunosuppressive as well as myeloablative potential with reduced toxicity, the role of serotherapy across the literature is not very well focused. But in our scenario, where most of our patients are class 2 class 3, as Satya sir has highly nicely elaborated, for these patients, both in terms of decreasing the graft rejection as well as the decreasing the incidence of GVHD, with particularly with the peripheral blood as a stem cell graft source. Given the choice, I will prefer ATG despite TTF as a conditioning regimen, and also this becomes more valid for unrelated donor transplants, because there the incidence of the GVHD as well as graft rejection is quite significantly higher compared to mass sibling donor transplants.
Thank you, Dr. Ganesh, for answering both the match-related and match-unrelated donor scenarios. Dr. Yadav says, so what will be your preferred serotherapy in haploidentical transplant settings for thalassemia major?
So yes, for haplo PTCY approach, I prefer to give a low dose ATG, 4.5 milligram per kg of rabbit ATG, and we tend to use it little distal from the like day -8, day -7, day -6, something like that. But there is some interesting data in leukemia where they're using it proximal, and in a couple of patients we have used it proximal also, especially in class 3 patients where the CRS was taken care of. The patient didn't have much of CRS, but both did get GVHD later on. So the data is still not there to recommend the right place and right timing of ATG, but it should be given in haplo PTCY, preferably little distal at this point of time, and low dose.
Thank you, sir. Thank you. Now moving on to early post-transplant complications. This is I'm just
Gaurav,
covering the...
Gaurav, we have about 5 minutes to conclude.
Sure,
so
sure.
we just take the
So I'll
important
just
questions and to the point.
Yeah, so I'll just be going through these important complications which have come up. So this is one important group of complications which have come up, early endothelial complications. So what are these complications and why have they gained so much of attention, Dr. Shantanu? Dr. Shantanu is not there, probably. Dr. Ruchira, would you like to take this?
Yep. So the endothelial complications that we see, like sir mentioned, was capillary leak syndrome that we often encounter around the time of engraftment. We see engraftment syndrome happening. We see peri-engraftment syndrome happening. We are very worried about veno-occlusive disease, especially of the liver, especially in our thalassemics and the ones that are class 3, because they often have iron overload and they may not be, so they tend to have more incidence of VOD in these patients. We've seen a higher incidence of press in our setting, which is also again endothelial damage leading to seizures and comes in because of the calcineurin inhibitors that we have, plus the endothelial injury that is already happening in our patients as well. So these are the few that we have come across.
Yeah. So yeah, thank you, Dr. Ruchira. So these are the group of disorders which come under this broad category: sinusoidal obstruction syndrome, formerly called as VOD, capillary leak syndrome, engraftment, peri-engraftment syndrome, diffuse alveolar hemorrhage, thrombotic microangiopathy, and posterior reversible encephalopathy. Now, VOD. So I mean, it has already been covered with the use of triosulfan, with the use of IV busulfan. Whenever the busulfan is being used, the incidence of VOD has significantly come down, and it also depends on how better we have prepared our patients. So I'll just skip this question. How would you look at sinusoidal obstruction syndrome in kids, Dr. Ganesh? Are the criteria different as compared to the adults?
So there is a EBMT criteria for VOD for pediatric population, which is not very different from the previously described Seattle as well as Baltimore criteria. But yes, based on this, so uh, the one important parameter apart from the conventional hyperbilirubinemia, weight gain, hepatomegaly, ascites in the EBMT pediatric criteria, going by the Baltimore or Seattle criteria, about some proportion of the pediatric population could not fulfill the criteria and were classical VOD, subsequently proved. So unexplained consumptive or transfusion refractory thrombocytopenia is a criteria which is included in the EBMT criteria. So probably that is one aspect which is different from the adult population.
Yeah. So these are the criteria. This is given by Selim and group. No limitation of time. This is first and most important thing. The classical thing starting from day -5 till day +35, that is not there. We have seen patients having at day 40, 45, 50 also developing features of VOD. The presence of 2 or more of the following: unexplained consumptive transfusion refractory thrombocytopenia, unexplained weight gain, hepatomegaly, probably better confirmed by imaging, ascites, and rising bilirubin. So these are the revised criteria, and based on these revised criteria, this was a nice review in EBMT in May 2020, that using these criteria, there was a significant reduction in the morbidity and mortality and overall the cost also when these revised criteria were used rather than the previous criteria. Moving on to another important complication which has gained attention recently. So we all are aware about the engraftment syndrome, the definition of engraftment syndrome, but this peri-engraftment syndrome is something which has come up recently, especially in alternative donor settings. So what is peri-engraftment syndrome, Dr. Anupam?
Basically, peri-engraftment syndrome, as per the name suggests, before the engraftment, the sign and symptoms like an engraftment happens, like fever, rash, and mild weight gain. So that comes under the criteria for diagnosing a peri-engraftment. And generally, we see, yes, in the haploidentical transplant, it is quite frequent. So, but in matched sibling transplant, also we see around 10 to 20% of the cases with this peri-engraftment syndrome-like symptoms.
True. So any association with conditioning or transplant setting, Dr. Shantanu? I think Dr. Shantanu is not there. So basically, we'll just go through this peri-engraftment syndrome. It is a syndrome which is like engraftment as described by Dr. Anupam. And the main differences with engraftment syndrome are development in context of malleability conditioning or reduced intensity conditioning, HSCT. Earlier presentation. So the presentation is earlier as compared to the engraftment syndrome. Okay, the fluid retention is seen in almost 30% of the cases. Important thing is whenever the patient develops pre-engraftment or peri-engraftment syndrome, there is less likelihood of graft failure, but the chances of having graft versus host disease is high as compared to the other patients who do not develop it. Moving on to another very, very important, I think this is a thing which we are seeing more and more often, which is transplant associated TMA, so microangiopathy. What is TMA, Dr. Ruchira?
Transplant associated microangiopathy is generally considered to be a triad of symptoms, which is manifested by hypertension, thrombocytopenia, which may be refractory as well, and you also get an elevated LDH, and there is breakdown of these cells happening. This could be related to a number of factors that may be associated, most commonly being the conditioning therapy, the underlying disease that you're treating for, and even the calcineurin inhibitors that we use as our post-transplant GVHD prophylaxis. on symptoms, we also, when I ask for a peripheral smear, we often see schistocytes, which helps to confirm the diagnosis of TA-TMA in our patients, that we see this.
So thank you, Dr. Uchira. Dr. Yadav, sir, you have a pretty wide experience of matched sibling donor, alternative donor, and various immunosuppressive agents also, which were available initially, and the newer ones which have come up. So, based on your personal experience, any thought about one immunosuppressive agent is better over other when it comes to TA-TMA setting?
So traditionally we have used cyclosporin. That's the commonly most wide experience we have is with cyclosporin in matched sibling and even in mud transplants. But now we have switched to PTCY with tacrolimus and MMF. So in both, hasn't been a huge difference, but somehow there is an option of sirolimus also, and we have found that if we are using sirolimus with MMF, the overall complications are less as compared to with tacrolimus or with cyclosporin. But this is just maybe a bias. I'm not sure that we haven't analyzed the data in a bigger, more detailed way. So I can't really comment. I think they all are equal, but sirolimus may have less complications possibly.
So yeah, sir, I do agree, because we also have the same kind of experience, and for past 3 years or 4 years, we have completely moved to sirolimus, and the complication rate, especially the TA-TMA, has come down significantly. So TA-TMA, I'll not go much into it. This all is available in the EBMT textbook, which we all have on our desktop. So we can go and just bridge through this particular complication, which is
Gaurav,
very,
we
very
need to wind
important
up
to
now, please.
Yeah. So patient-related factors, late HSCT complications. So transplant, especially for diseases like thalassemia, doesn't end with the day 28 or day 100. I mean, these patients need to be followed up on a long-term basis for other post-transplant long-term complications, the organ dysfunction. So this is what we need to be careful about. Regular follow-up is required for these patients. So we'll move on. And I think with this, I would like to thank you all. Thank you, all the panelists, for your inputs pertaining to the burning issues which we often face while managing these patients with thalassemia major. So thank you all. And
thank you, Gaurav.
Thank you, Gaurav, for your
Any
effort.
questions,
I'm
Sunil?
sorry
Would you like to
cut you
take?
short because it's a long topic, and I think we should.
I know.
We'll have to catch up
Sunil,
again with transplant and thalassemia, I think.
so any questions which are there in that text box?
So I think we have
I've
sorted
answered
out
the
all of them, except for
Everything
one.
okay.
I think there was a question on fertility preservation. So if someone wants to take that, so Maruchan, I want to take one on fertility preservation and fertility.
Yes,
in
there's a lot of data
discussed.
coming in. There is an incidence, a higher incidence of hypogonadism in patients who have undergone transplant for thalassemia.
Yeah.
But what we have also found that there is females who've undergone transplants still have the childbearing potential, and there are case reports coming in where these women have had babies after transplant as well. So all the cases not all lost. We still have hope, and we're hoping that more and more people will report this, and we'll have fertility coming up in the future as well. So
I agree, and with the treosulfan thiopurine conditioning, we don't have enough long-term data. There is some
not
potential, and there was a very
so far.
elegant
Yes, but
study from
treosulfan is
Apollo
supposed
Chennai.
to be more protective towards your fertility.
So this was about the conditioning, but what is your strategy on fertility preservation? So especially when you have sort of teenage kids who are undergoing transplants. So do you offer it routinely?
So all our males that come in, Gaurav, who are adolescent and have started masturbation, we would definitely talk to them about sperm preservation. It's a very delicate topic to talk about, but I think over the years we've realized that we need to talk about it.
Exactly.
The younger ones, using testicular biopsies and trying to offer them some kind of cryopreservation techniques, we are not offering those at the moment at all. For the females, again, if they are post-pubertal, the option is put there to have an oocyte preservation done, but not a single patient has actually opted for it till now. And since we don't do adults, I really can't talk about embryo preservations at all.
So thank you very much. I think that covers the spectrum, and I should thank Gaurav and the whole esteemed panel. It's been really interactive and learning experience for all of us. But I really think that this time is not enough. I think we'll have to meet again. So I take opportunity to thank the CELON labs also, who have kindly provide this platform to all of us. And before we conclude, I hand it over to Mr. Mahesh from CELON, who has been instrumental in bringing us all together. I think this started a few weeks ago when he made a phone call and said, we want to do something on thalassemia. I said, it's a wonderful idea. So Mr. Mahesh, over to you, and thank you from all of us for having us all on this platform.
Thank you, sir. Good evening, everyone. My name is Mahesh Tamane, and I'm from CELON Labs. It is my honor and privilege to deliver the vote of thanks on this memorable occasion. We at CELON are committed towards providing quality medicines to patients and partner with you to support in achieving the common goal of providing quality to the patients. I express my sincere gratitude and thank Program Director Dr. Sunil Bhatt for his efforts towards conceptualizing the entire program and giving us an opportunity to participate in this important scientific event. I also extend my heartfelt thanks to Dr. Satyendra Kateva for his informative talk on HSCT in thalassemia, risk stratification, and reduced intensity conditioning. Dr. Gaurav Tharia for moderating the panel discussion, complication, post-HSCT in thalassemia. We are grateful to all the eminent hematologists who were there in the panel, that is Dr. Satyaprakash Yadav, Dr. Anupam Chakrapani, Dr. Ganesh Jaishetwar, Dr. Shantanu Sen, and Dr. Ruchira Mishra. I thank all the distinguished delegates who attended today's webinar, accepting our invitations. We assure you of continuous support to such activities in the times to come. I also mention special thanks to MICE Ideas for seamless execution of the program, and also the CELON Oncology team for their efforts in making this event. More than 380 delegates attended this program, so it was their hard work. So I really appreciate their hard work. I thank all of you for sparing your valuable time from your busy schedule and attending this program and encouraging us in our endeavor of taking scientific initiative in terms of CMS, that is webinar today we did. Thank you so much. Good night.
Thank you very much, Mahesh, for your kind words. And I think I was told by MICE Ideas that because I was a little restless after 7:20 that we are just encroaching on the time, but he told me that no one has logged off. So it was, I think, most importantly, it was, I think, helpful for a lot of us. So thank you very much for having us, and good night.
Thank you so much, sir.
Everyone.
Thank you.
Thank you all. Thank you, Mahesh. Thank you.
Thank you, sir. Take care. Bye.
Thank you, sir. Bye-bye. Bye, sir.